Why is regular screening for diabetic retinopathy essential, and what are the recommended guidelines for its prevention and management? Answer: especially in patients with type 1 or type 2 diabetes, without early intervention, retinopathy can progress to blindness. Screening guidelines include type 1 diabetes, screen after 5 years of diagnosis and annually thereafter. Type 2 diabetes, initial screening at diagnosis, then annually. Prevention strategies: glycemic control. Keeping HbAc levels below 7% reduces retinopathy risk. Blood pressure control. Maintaining BP under 104 to 9 mHg helps prevent further complications. Lipid management. Statins lower cardiovascular risk. Management of advanced retinopathy. Laser photocoagulation is used to prevent vision loss by targeting damaged blood vessels. Anti-VEGF injections treat macular edema. The ADA standards of care recommend these interventions, ensuring timely detection and management to prevent severe complications. Mrs. Carter, a 45-year-old woman with type 2 diabetes, reports frequent episodes of shakiness, sweating, and confusion during late afternoons. She has been on a sulfonylurea and adheres to a low-carb diet. Her fasting glucose readings are 90100 DDL. What could be causing these symptoms, and what adjustments should be made? Answer: Mrs. Carter is experiencing symptoms of hypoglycemia likely due to sulfonylurea-induced insulin release combined with her low-carb diet. Sulfonylureas increase insulin secretion, which can cause glucose levels to drop if dietary intake is insufficient. Causes: the sulfonylurea may stimulate insulin too much, especially with inadequate carbs, causing blood glucose to fall. The low-carb diet provides insufficient glucose, exacerbating hypoglycemia. Interventions: medication adjustment, switch to medications with a lower hypoglycemia risk, such as EPP4 inhibitors or SLT inhibitors. Dietary changes ensure balanced meals with appropriate carbs, proteins, and fats to stabilize blood glucose. Glucose monitoring: advise frequent monitoring to prevent hypoglycemic episodes. For treatment, rule of 15: administer 15 grams of fast-acting carbohydrates and recheck glucose after 15 minutes. Compare and contrast the effectiveness of one-on-one DSME sessions versus group education in managing diabetes. Answer: one-on-one DSMEs. Advantages: personalized care tailored to individual needs, including lifestyle, literacy, and cultural preferences. It allows for deeper discussions of personal challenges and solutions. Disadvantages: time-consuming and resource-intensive for healthcare providers, potentially limiting accessibility. Group education. Advantages: offers peer support, creating an environment where patients can share experiences and learn from each other. It is more cost-effective and allows for broader outreach. Disadvantages: may not address specific individual needs or personal challenges. Group dynamics may reduce engagement from some participants. Effectiveness comparison: both methods can be equally effective in improving clinical outcomes like HbAc, provided that the content is relevant and participants are actively engaged. The AIDA's standards of care suggest that tailoring education delivery to patient preferences, e.g., group or one-on-one, ensures optimal outcomes. Explain the role of problem-solving in diabetes self-management and provide an example of how it can be applied to overcome barriers. Answer: problem solving is essential in diabetes management as it helps patients overcome barriers to effective self-care. By identifying problems and developing strategies, individuals can better manage their diabetes and improve outcomes. Example: a patient experiences high post-meal blood sugar despite taking the correct insulin dose. Problem-solving steps would include: review the meal. Is the carbohydrate content higher than expected? Examine insulin timing. Is insulin being taken at the right time relative to meals? Evaluate physical activity. Is there less exercise than usual, which could affect insulin sensitivity? Develop a solution. Adjust insulin timing or dose, or alter the diet to reduce carb intake. This process empowers the patient to actively manage their diabetes, aligning with the ODD self-care behaviors framework, which emphasizes proactive problem solving to enhance self-efficacy and outcomes. Outline the diagnostic criteria for diabetic ketoacidosis (DKA) and describe the initial treatment protocol. Answer: diagnostic criteria for DKA: hyperglycemia, blood glucose 215 ml, acidosis, arterial pH 7.3 and bicarbonate 18 methyl ketonemia ketonuria. Presence of ketones in blood or urine. Initial treatment protocol: fluid resuscitation. Administer isotonic saline 0.9% NaCl to correct dehydration, typically starting with 1.5 over the first hour. Insulin therapy. Start an IV infusion of insulin 0.1 units to reduce blood glucose levels. Electrolyte management. Potassium should be monitored and supplemented if necessary, particularly if 5.3 meckel. Acidosis correction. Avoid bicarbonate unless the pH drops below 6.9. Monitor. Continuous monitoring of blood glucose electrolytes and vitals is crucial. These steps follow ADA guidelines for diabetic ketoacidosis management, ensuring the safe correction of metabolic abnormalities while avoiding complications such as hypokalemia. Discuss the importance of lipid management in diabetes and the primary pharmacological options available. Answer. Diabetes significantly increases the risk of cardiovascular disease (CVD) due to the combined effects of hypoglycemia, hypertension, and dyslipidemia. Lipid management is crucial for reducing this risk. Lipid targets. EDIL-C, target 4 ml in men and 15 ml in women. Triglycerides should be kept under 150 ml. Pharmacological options. Statins. First-line treatment, such as atorvastatin or rosuvastatin, effectively lower LDL cholesterol. Ezetimibe, used in combination with statins when LDL goals are not met. PCSK inhibitors, reserved for patients with familial hypercholesterolemia or high cardiovascular risk, such as evolocumab. By following the AIDAS standards of care, clinicians can tailor lipid-lowering strategies to reduce CVD risks, addressing the multifaceted nature of diabetes management. What are the exercise recommendations for individuals with diabetes, and how should they adjust for potential complications? Answer. Exercise plays a key role in diabetes management by improving insulin sensitivity and cardiovascular health. Exercise recommendations. Aerobic exercise. At least 150 minutes per week of moderate intensity aerobic activity, e.g., brisk walking or cycling. Resistance training. At least 2 sessions per week to improve muscle mass and insulin sensitivity. Adjustments for complications. Retinopathy. Avoid high-impact activities that may increase the risk of retinal hemorrhage. Neuropathy. Low-impact activities like swimming or cycling are safer to reduce foot injuries. Foot care. Always inspect feet for cuts or sores before and after exercise. These recommendations are consistent with the AIDAS physical activity exercise standards, ensuring both safety and effectiveness for patients with diabetes. How can behavioral outcomes in DSM-ES programs be evaluated? Answer. Evaluating behavioral outcomes in diabetes self-management, education, and support. DSMES focuses on assessing improvements in self-care behaviors. This can include self-monitoring of blood glucose (SAG), increased frequency of blood glucose testing, a key behavior in diabetes management. Dietary changes, improvement in eating habits, such as adopting a balanced, low-glycemic diet, medication adherence, a decrease in missed doses, and increased compliance with prescribed therapies. Tools like the Diabetes Self-Management Questionnaire (DIQ) measure behavioral outcomes by evaluating various dimensions of self-care. These assessments align with the ODD self-care behaviors framework, helping healthcare providers tailor interventions based on the patient's progress in these key areas. What are the different types of insulin available, and how are they used in managing diabetes? Answer. Diabetes. Types of insulin. Rapid-acting includes insulin lispro, aspart, and glulisine, used before meals to control postprandial glucose spikes. Short-acting, regular, used 30 minutes before meals, works for 3-6 hours. Intermediate-acting, NPH, provides basal insulin coverage for 1-6 hours. Long-acting, glargine detemir, provides steady insulin levels for 24 hours, used for basal coverage. Insulin regimens. Basal bolus regimen combines long-acting insulin for basal control and rapid-acting insulin before meals for bolus coverage. Fixed combination regimens use a mix of short or intermediate-acting insulin for simplicity. Proper use of these insulins, along with appropriate monitoring, is critical to maintain optimal glucose control and prevent complications. Describe the benefits and challenges of continuous glucose monitoring (CGM) in diabetes management. Answer. Benefits of CGM. Real-time data provides continuous feedback on glucose trends, helping patients adjust insulin therapy and lifestyle habits. Early detection detects hypoglycemia and hypoglycemia before symptoms appear, allowing for timely intervention. Improved glycemic control. Studies show that CGM use can lower HbAC and reduce time spent in hypoglycemia. Challenges. Cost. CGMs can be expensive, limiting access for some patients. Sensor accuracy. While CGM accuracy has improved, occasional calibration may be required. Despite these challenges, the ADA recommends CGMs for patients with type 1 diabetes, especially those who require intensive insulin therapy, as they significantly improve management and reduce complications. Sarah is a 13-year-old recently diagnosed with type 1 diabetes. She is struggling to manage her glucose levels at school due to irregular meal times and frequent physical education classes. Sarah's mother reports that her daughter is feeling self-conscious about injecting insulin in front of her peers, and as a result, she occasionally skips doses. As a certified diabetes care and education specialist, how should you address this situation to help Sarah manage her condition more effectively? Answer. Sarah requires an individualized education plan that includes instruction on insulin's critical role in diabetes management and how skipping doses can lead to complications like DKA. Education should also address age-appropriate concerns, such as how insulin impacts daily activities. Collaboration with Sarah's school is essential. A 504 plan can provide accommodations, ensuring access to a private space for insulin administration and adjusted meal times. This is a legal requirement for students with chronic conditions, ensuring fair treatment. Address Sarah's emotional barriers by discussing alternative, less conspicuous injection methods like insulin pens or pumps, which provide privacy. Emotional support is key for young patients, and involving a counselor can help her feel more confident. For physical activity, education on managing blood glucose levels during exercise is essential. Sarah should learn to check her glucose pre and post activity and adjust accordingly. Offering educational resources on diabetes management tailored to her age can foster both understanding and confidence. Why is polypharmacy a critical concern in managing diabetes among older adults, and how should it be addressed in practice? Answer. Polypharmacy is a major concern in older adults due to their increased likelihood of comorbid conditions like hypertension, heart disease, and arthritis, which often require multiple medications. The risk arises from drug-drug interactions, which can result in adverse events such as hypoglycemia, cognitive decline, and increased hospitalizations. To address this, a medication review should be conducted regularly using resources like the Beers criteria, which identifies potentially inappropriate medications for older adults. Healthcare professionals should evaluate the necessity and safety of each drug, considering factors such as renal function and polypharmacy risks. Reducing the pill burden by simplifying regimens is another strategy. For example, opting for combination therapies, e.g., a single pill for diabetes and hypertension, can improve adherence and reduce confusion. Medication adjustments should be made cautiously, especially with insulin and sulfonylureas, which are associated with increased hypoglycemia risk in the elderly. Education on managing diabetes while accounting for other health conditions is crucial. What are the recommended blood glucose targets for pregnant individuals with diabetes, and why are they stricter compared to non-pregnant populations? Answer. In pregnancy, blood glucose targets are stricter due to the risk of adverse outcomes for both the mother and the fetus. The targets recommended by organizations such as the American Diabetes Association are fasting blood glucose, 95 mdl 1 hour postprandial, 100 for mgl 2 hour postprandial, 120 mgdl. These stricter targets help reduce the risk of macrosomia, which can lead to difficult deliveries and increased likelihood of birth injuries. High maternal blood glucose levels also increase the risk of neonatal hypoglycemia, as the fetus's pancreas produces excess insulin in response to the mother's hypoglycemia. Additionally, uncontrolled blood glucose can cause congenital malformations during organogenesis, especially in the first trimester. For mothers, poorly controlled glucose levels can increase the likelihood of developing gestational hypertension or preeclampsia, which are associated with significant maternal morbidity. The placental function is impaired when blood glucose levels are not well controlled, limiting oxygen and nutrients to the fetus. Therefore, maintaining strict glycemic control is crucial not only for fetal development, but also for maternal well-being. Explain the role of team-based care in managing diabetes and how it improves outcomes. Answer. Team-based care involves collaboration between various healthcare professionals to manage diabetes. This approach is essential because diabetes management requires multifaceted care that extends beyond medical treatment. The team typically includes endocrinologists, diabetes educators, dietitians, pharmacists, and sometimes social workers and psychologists. Comprehensive management. Each team member brings specialized expertise. The endocrinologist handles complex cases and adjusts insulin regimens, while dietitians focus on nutrition planning tailored to the patient's lifestyle. Improved adherence. Pharmacists ensure medication safety, educate patients on correct usage, and monitor for drug interactions or adverse effects. Diabetes educators reinforce lifestyle changes and teach patients self-management techniques. Psychosocial support. Psychological care is crucial for patients coping with diabetes-related stress. Social workers or mental health professionals provide support for patients facing depression, anxiety, or other barriers to diabetes management. Evidence of effectiveness. Studies show that team-based care improves outcomes by reducing AC, preventing complications, and improving patient quality of life. Mr. Thompson, a 75-year-old patient with type 2 diabetes, has recently experienced several episodes of nocturnal hypoglycemia. His current medications include insulin glargine, metformin, and glimepiride. He also takes medications for hypertension and arthritis. What steps should be taken to reduce Mr. Thompson's hypoglycemia risk without compromising glycemic control? Answer: evaluate insulin therapy. Insulin glargine may be causing prolonged hypoglycemia at night, especially in older adults with reduced renal function. Consider switching to insulin degludec, which has a flatter, longer-acting profile. Review sulfonylurea use. Glimepiride as sulfonylurea can increase the risk of hypoglycemia, particularly in the elderly, due to decreased renal clearance. Consider substituting glimepiride with an E4 inhibitor or GLP-1 receptor agonist, which have a lower risk of hypoglycemia. Assess renal function. Declining renal function in older adults can result in prolonged drug action. Check Mr. Thompson's renal function and adjust the medication doses accordingly. Monitor meals and physical activity. Encourage regular meals and snacks to prevent hypoglycemia, especially before bedtime. Make sure Mr. Thompson is also adequately managing physical activity, as exercise increases the risk of hypoglycemia. Use continuous glucose monitoring (CGM). Implement CGM to provide real-time glucose readings, allowing better adjustment of insulin therapy to avoid nocturnal hypoglycemia. What factors should be considered when planning diabetes management in children undergoing puberty? Answer: puberty increases insulin resistance due to hormonal changes, which complicates diabetes management in children. Key factors to consider include increased insulin needs. During puberty, growth hormone and sex hormones like estrogen and testosterone increase insulin resistance, requiring adjustments in insulin dosage. Behavioral factors. Adolescents may experience fluctuating moods and a desire for independence, which can affect adherence to diabetes management plans. This stage also involves peer pressure and body image concerns, making adherence to insulin injections or devices challenging. Cognitive and emotional support. Adolescents need education on diabetes that matches their cognitive development, using practical examples to explain the importance of consistent care. Offering emotional support, including involvement in support groups, is essential. School and social life. Adjustments to meal times and exercise schedules in coordination with schools can prevent blood glucose fluctuations. Peer education can also reduce stigma around diabetes. Parental involvement. Parents should still play a vital role in managing the condition, but also encourage independence as the child matures. How does addressing health disparities improve diabetes outcomes, and what strategies can be employed? Answer: addressing health disparities is crucial for improving diabetes outcomes, especially in underserved communities where access to healthcare may be limited. Strategies include community programs, diabetes prevention programs, including free education and screening in underserved communities, provide crucial information and early intervention. Insurance advocacy. Many patients face barriers to accessing necessary medications and devices. Diabetes educators can advocate for better insurance coverage for critical supplies like insulin and continuous glucose monitors. Culturally competent care. Tailoring diabetes education to reflect the cultural preferences and values of patients enhances engagement. This includes incorporating traditional dietary preferences and family structures into care plans. Health literacy. Programs that increase health literacy empower patients to make informed decisions, improving self-management and reducing complications. Improving access to care. Increasing access to care through telemedicine and mobile health initiatives can help bridge gaps in healthcare delivery. What are the key considerations when managing diabetes in older adults with cognitive impairment? Answer: managing diabetes in older adults with cognitive impairment requires simplified regimens. Simplify diabetes management regimens to improve adherence, such as using combination therapies or long-acting insulins. Increased supervision. Caregivers should be involved in monitoring blood glucose levels, administering insulin, and ensuring medication adherence. Safety concerns. Cognitive impairment increases the risk of hypoglycemia. Continuous glucose monitoring (CGM) can help mitigate this risk by providing real-time alerts. Clear communication. Use clear, simple instructions and consider the cognitive capacity of the individual when explaining treatment regimens. Regular assessments. Frequent assessments of both cognitive function and diabetes management are crucial to identify any necessary changes in treatment. How does exercise impact diabetes management, and what are the key recommendations for people with diabetes? Answer: exercise plays a crucial role in managing diabetes by improving insulin sensitivity, lowering blood glucose, and reducing cardiovascular risk. Key recommendations include regular physical activity. Adults with diabetes should aim for at least 150 minutes of moderate intensity aerobic activity per week, combined with strength training at least twice a week. Monitoring blood glucose. Before and after exercise, blood glucose should be monitored to adjust insulin or carbohydrate intake accordingly. Individualized plans. Exercise programs should be personalized to accommodate fitness levels, age, and comorbid conditions. Safety measures. Those on insulin or sulfonylureas should be educated about preventing hypoglycemia during or after exercise. What are the potential benefits and risks of UZLT inhibitors in patients with diabetes and chronic kidney disease? C. Answer: SLT inhibitors, such as canagliflozin and empagliflozin, are beneficial for patients with diabetes and chronic kidney disease (CKD) because they offer renal protection and improve glycemic control. Benefits: renal protection. ADLT inhibitors reduce albuminuria protein in urine, which is a key marker of kidney damage in diabetes. They also slow the progression of CKD by reducing glomerular hyperfiltration and controlling blood glucose levels. Cardiovascular benefits. These drugs have been shown to lower the risk of heart failure, hospitalization, and major cardiovascular events in patients with diabetes and CKD. Weight loss and blood pressure reduction. SLT inhibitors contribute to modest weight loss and low blood pressure, further improving metabolic control. Risk of dehydration. By promoting glucose and sodium excretion in urine, these medications increase urination, potentially leading to dehydration and hypotension, particularly in elderly patients. Genital infections. Increased glucose in the urine can increase the risk of genital fungal infections, especially in women. Diabetic ketoacidosis (DKA). Although rare, ADLT inhibitors can increase the risk of euglycemic DKA, especially under conditions of stress or illness. Careful monitoring of kidney function, hydration status, and signs of infection is essential when prescribed SLT inhibitors to patients with diabetes and CKD. Explain the role of balancing macronutrients in achieving glucose stability in diabetes management. How can the glycemic index and glycemic load assist in this process? Answer: balancing macronutrients. Carbohydrates, proteins, and fats is crucial for maintaining glucose stability in diabetes. Carbohydrates have the most direct effect on blood glucose, while proteins and fats influence glucose absorption and insulin response. A well-balanced diet ensures gradual glucose absorption, avoiding sharp peaks or dips. The glycemic index (GI) measures how quickly foods raise blood glucose levels. Foods with a high GI cause rapid glucose spikes, while low GI foods provide steady glucose release, helping manage blood sugar more effectively. The glycemic load (GL) takes portion size into account, offering a more accurate reflection of how food affects blood glucose. Foods with low GI and GL values have been shown to reduce HbAC and improve overall glycemic control. Implementing a diet rich in low GI foods (G) whole grains, legumes, and balancing protein and fats alongside carbohydrates helps avoid post-meal glucose spikes. Guidelines from the ADA suggest using GI and GL as part of an individualized nutrition plan to improve long-term diabetes outcomes, reduce cardiovascular risk, and improve insulin sensitivity. Describe the biochemical mechanisms behind glucose uptake during and after exercise in individuals with diabetes. How do these mechanisms differ between type 1 and type 2 diabetes? Answer: during exercise, glucose uptake into muscle cells increases through both insulin-independent and insulin-dependent mechanisms. The insulin-independent pathway is activated by muscle contractions, which stimulate the translocation of GLUT4 transporters to the cell membrane, allowing glucose to enter muscles directly. This process is particularly important in individuals with type 2 diabetes, where insulin resistance hinders glucose uptake. The insulin-dependent pathway involves insulin's role in promoting GLUT4 translocation, improving glucose uptake in muscle cells post-exercise. In type 1 diabetes, since the body produces little to no insulin, individuals must adjust insulin doses to prevent hypoglycemia, especially during prolonged or intense activity. For type 2 diabetes, exercise improves insulin sensitivity, making insulin more effective at lower levels. Regular physical activity in type 2 diabetes can reduce insulin resistance, improving long-term glucose control. The ADA recommends that people with diabetes engage in regular exercise to enhance both insulin-independent glucose uptake and overall insulin sensitivity. Amara, a 35-year-old woman with type 1 diabetes, plans to participate in a tank run. She usually takes 10 units of rapid-acting insulin before breakfast. How should she adjust her insulin dose and carbohydrate intake to prevent hypoglycemia during and after the run? Answer: Amara should reduce her pre-run rapid-acting insulin dose by 3050% as exercise increases insulin sensitivity and can lower blood glucose. For a tank run, reducing the dose by about 30% might be appropriate, but she should monitor blood glucose levels before and after the exercise. She should also consume 1530 grams of carbohydrates 1530 minutes before starting the run to provide a steady energy supply, ensuring glucose levels stay stable throughout the run. Amara should carry fast-acting carbohydrates like glucose tablets in case of hypoglycemia during the race. After the run, she should monitor blood glucose more frequently to ensure levels do not drop too low due to increased insulin sensitivity. Following exercise, her insulin needs may be temporarily reduced as muscle cells continue to take up glucose for recovery. The ADA emphasizes the importance of pre- and post-exercise glucose monitoring and carbohydrate management, particularly for those using insulin. Compare and contrast the Mediterranean diet and the DASH diet in managing diabetes and cardiovascular disease risk. Include evidence-based recommendations. Answer: both the Mediterranean diet and the DASH diet are beneficial for diabetes management and reducing cardiovascular risk, but they have distinct focuses. The Mediterranean diet emphasizes healthy fats, particularly olive oil, lean proteins like fish, and high consumption of fruits, vegetables, and whole grains. It has been shown to improve insulin sensitivity, reduce inflammation, and lower the risk of heart disease. Studies suggest that it can improve glycemic control and lower HbAC in individuals with diabetes. The DASH diet, dietary approaches to stop hypertension, focuses on reducing sodium intake and increasing consumption of potassium, magnesium, and fiber. It promotes fruits, vegetables, whole grains, and lean proteins while limiting processed foods, which can help control blood pressure and reduce the risk of stroke and heart disease. The DASH diet is particularly effective for managing hypertension, which is common in people with diabetes. Both diets encourage the consumption of nutrient-dense foods, supporting glycemic control and overall heart health. ADA and AHA guidelines endorse both diets for managing diabetes and reducing cardiovascular risk. Individuals should choose based on their dietary preferences and specific health goals. What precautions should be taken to prevent exercise-induced hypoglycemia in individuals using insulin or insulin secretagogues? Answer: to prevent exercise-induced hypoglycemia, individuals using insulin or insulin secretagogues should take several precautions. Monitor blood glucose levels before, during, and after exercise to identify any trends or need for adjustments. Reduce insulin doses before exercise, typically by 3050%, depending on the type, intensity, and duration of activity. This prevents insulin from causing a glucose drop during exercise. Consume carbohydrates if blood glucose is below 100 mdl before exercise, and ensure that fast-acting carbohydrates are available during the workout. Avoid exercising during peak insulin activity when insulin levels are high, as this increases the risk of hypoglycemia. Hydrate well, as dehydration can exacerbate hypoglycemia risk. Individuals using insulin secretagogues, which stimulate insulin production, need to be particularly cautious during exercise, as their bodies may produce more insulin than needed. The ADA guidelines suggest adjusting insulin doses and monitoring blood glucose more frequently when engaging in physical activity, particularly for those on insulin therapy. How can cultural dietary practices influence the management of diabetes, and what strategies should educators use to address these? Answer: cultural dietary practices significantly influence food choices, meal timing, and portion sizes, which directly impact diabetes management. For instance, fasting during Ramadan or certain religious holidays might affect blood glucose control due to altered meal timing and food intake patterns. Educators should adopt a culturally sensitive approach, incorporating culturally appropriate foods while emphasizing balance and portion control. For example, if a patient follows a vegetarian diet, the educator should focus on plant-based sources of protein and low-G carbohydrates. Educators should also address cultural norms around meal frequency and snack types, ensuring that patients understand how to make healthier choices. Practical recommendations might include adjusting medication doses, especially insulin, to account for changes in meal patterns or providing culturally tailored carbohydrate counting methods. ADA guidelines recommend personalized meal plans that reflect both cultural preferences and nutritional goals to enhance adherence and glycemic control. Explain the FITT frequency, intensity, time, type principles for designing an exercise plan for a person with diabetes. Answer: the FITT principles help guide exercise planning for people with diabetes, ensuring that physical activity aligns with health and glucose management goals. Frequency: individuals should aim for at least 3-5 days of exercise per week to optimize insulin sensitivity and glycemic control, with no more than 2 consecutive days off to maintain benefits. Intensity: a moderate to vigorous intensity defined as 40-70% of VO max or a perceived exertion level of 1-1.6 is recommended. This intensity promotes both cardiovascular health and effective glucose management. Time: a total of 150 minutes of aerobic exercise per week is recommended, with 30 minutes of moderate exercise on most days. Strength training should be included 2-3 times per week. Type: aerobic activities, e.g. walking, cycling, improve cardiovascular health, while resistance training, e.g. weightlifting, enhances muscle strength and insulin sensitivity. By following the FITT principles, individuals can improve insulin sensitivity, reduce HbAC, and lower cardiovascular risk. The ADA recommends a mix of aerobic and resistance exercises to achieve optimal benefits. David, a 50-year-old man with type 2 diabetes, is traveling internationally. What steps should he take to manage his nutrition and blood glucose during the trip? Answer: David should take several steps to manage his diabetes while traveling. Pack nutritious snacks such as nuts, granola bars, and fruit to avoid high-sugar airport snacks and ensure stable blood glucose. Adjust insulin and medication timing based on the new time zone and be mindful of meal schedules. He may need to consult with his healthcare provider for adjustments. Stay hydrated by drinking water or electrolyte-rich drinks, avoiding sugary beverages. Carry medical documentation for insulin and other medications to prevent issues at security checkpoints and ensure proper accommodations in case of delays. Monitor blood glucose levels frequently, as travel stress and changes in activity and meal timing can cause fluctuations. By preparing ahead of time and remaining vigilant, David can maintain control over his diabetes while traveling. The ADA stresses the importance of planning for meals, medication, and blood glucose monitoring during travel to prevent complications. How can someone with diabetes manage blood sugar fluctuations during high-intensity exercise? Answer: during high-intensity exercise, blood sugar fluctuations can occur due to the body's increased energy demand. For those with diabetes, managing these fluctuations requires pre-exercise blood glucose monitoring, adjusting insulin doses, and carbohydrate intake. Before high-intensity activities, individuals should check their blood glucose levels. If glucose is below 100 mdl, consuming 1.53 grams of carbohydrates is advised. Reducing insulin doses before exercise can prevent post-exercise hypoglycemia, as exercise enhances insulin sensitivity. If glucose levels rise during exercise, it may indicate insufficient insulin and additional adjustments may be needed. Post-exercise glucose monitoring is important, as blood glucose can remain low for several hours after high-intensity exercise. Regular exercise can improve insulin sensitivity, reducing the frequency of glucose fluctuations over time. The ADA recommends personalized strategies to prevent hypoglycemia and maintain steady glucose levels during physical activity, including using continuous glucose monitors (EGMS) to track changes in real time. How does renal impairment affect the management of diabetes, and what dietary considerations are important for patients with diabetic nephropathy? Answer: renal impairment in diabetes, known as diabetic nephropathy, complicates glucose control and increases the risk of complications. The kidneys play a critical role in filtering excess glucose and waste products, but in nephropathy, this function deteriorates. Managing diabetes in the presence of renal impairment involves careful control of blood glucose, blood pressure, and protein intake. A low-protein diet may be recommended to reduce kidney workload. Additionally, patients with diabetic nephropathy need to monitor potassium, phosphorus, and sodium intake to prevent electrolyte imbalances. Tight glycemic control is critical to slowing the progression of kidney damage. ADA guidelines suggest individualized nutrition plans that account for both diabetes and renal health. Regular monitoring of kidney function and adjustment of medication, particularly ACE inhibitors or ARBs, may also be necessary to protect kidney function.